Hello everyone. I am myself Dr. Rajesh Guba. I am the general medicine educator. So in this session, I'll be discussing the test and discussion of general medicine. So if you take the first question, treatment of choice for the ST elevation MI, thrombolysis with altiplase, tissue plasminogen activator with streptokinase, primary percutaneous coronary intervention, low molecular weight heparin. So in case of the ST elevation MI, which comes under your acute coronary syndrome, what exactly is the first line drug? The first line drug that we give is the aspirin. And along with the aspirin, we give clopidogrel and as well as the atorvastatin loading doses. Followed by that, we need to do the revascularization procedure. Now, what are the various methods of revascularization procedure in case of the STEMI is? We do PCI, that is percutaneous coronary intervention, or the PTCA, percutaneous transluminal coronary angioplasty, that is number one. The other method of the revascularization is thrombolysis, right? And the third method of the revascularization, it is the coronary artery bypass graft. So these are the three methods of the revascularization. Now, out of which the best method of the revascularization is the percutaneous coronary intervention. That is the best method, right? Now, you take thrombolysis only in the hospitals where the PCA is not available. That is the place where we need to do thrombolysis and do revascularization. And thrombolysis, it is done with the help of the thrombolytic agents, that is streptokinase, then followed by that the urokinase, then we have altiplase, then retiplase, and next tenecteplase, right? So these are the various thrombolytic agents, and out of which the tenecteplase is the one which will cause maximum revascularization of the coronaries then compared to that of the other thrombolytic agents. Then whereas you take CABG, when is this coronary artery bypass graft indicated is mainly when the patient is having a triple vessel disease. That is when the coronary artery bypass graft is indicated. So these are the various methods of revascularization, and the best method of revascularization in case of STEMI is primary percutaneous coronary intervention. Whereas you take low molecular weight heparin. Now, in which form of the ischemic heart disease or acute coronary syndrome we give low molecular weight heparin? So low molecular weight heparin, which is an anticoagulant, and we have another important anticoagulant, that is the fondaparinux. So these two, that is low molecular weight heparin and as well as the fondaparinux, these two anticoagulants, they are given in cases of the NSTEMI, right? That is non-ST elevation MI, and as well as the unstable angina, right? As well as the unstable angina. So these are the two clinical conditions where we give fondaparinux or low molecular weight heparin initially, and once the individual is stabilized, then the individual has to undergo coronary angiogram, and if the coronary angiogram shows a blockade of more than 70%, that is the when, right? That is when we need to plan for the percutaneous coronary intervention. So this is about the revascularization in cases of the ischemic heart diseases. Next question. Digitalis is used in mitral stenosis when patient develops atrial fibrillation, right ventricular failure, acute pulmonary edema, and then myocarditis. So please remember, in case of the mitral stenosis, what are actually the drugs which are being preferred? The drugs which are being preferred in mitral stenosis is number one, diuretics. That is mainly to prevent the development of the pulmonary edema and as well as further to reduce the pulmonary hypertension. Then the next important group of drugs which are given in the treatment of the mitral stenosis are beta blockers. So these two are the important group of drugs that we give in patients with the mitral stenosis. But in patients with mitral stenosis, one of the very important finding that you will have is left atrial enlargement, right? So there will be left atrial enlargement. Now this left atrial enlargement is the one which makes the heart to go into a state of the atrial fibrillation, right? So secondary to this left atrial enlargement, there will be development of the atrial fibrillation. Now, whenever the individual develops atrial fibrillation, how is that you can control the rate or control the atrial fibrillation is by giving the digitalis. So digitalis we give in patients with mitral stenosis mainly when they develop the atrial fibrillation. And what could be the reason for right ventricular failure in patients with mitral stenosis? In patients with mitral stenosis, when they develop pulmonary hypertension due to reversal of the flow, there can be increased afterload on the right ventricle that will result in right ventricular failure. Now, acute pulmonary edema you will observe in cases of mainly very severe form of mitral stenosis. Now, what do you understand by this word very severe form of mitral stenosis is where the valve area will be, right, where the valve area will be less than 1 centimeter square. That is what is your very severe mitral stenosis, and that is when the chances of acute pulmonary edema is very common. And myocarditis, right, it is usually not observed in patients with mitral stenosis. So in mitral stenosis, when do we use digitalis? When a patient with MS develop atrial fibrillation, we use digitalis or digoxin mainly to control the rate, right? Next question. Which is the best way to differentiate the stable angina and as well as the non-ST elevation MI? The options are ECG, cardiac biomarkers, transthoracic echocardiography, multi-uptake gated acquisition scan, which is nothing but MUGA scan. Now, what is the best way to differentiate the stable angina and as well as STEMI is? Now, let me just give you the spectrum of the coronary artery disease. So, if you see the spectrum of the coronary artery disease, number one, we have ischemic heart disease, and the other one is the infarction, right? So these two important disorders or these two important entities, they form the spectrum of the coronary artery disease. Now, in case of ischemic heart diseases, right, in case of ischemic heart diseases, like we have the three important entities, that is stable angina, right, that is stable angina, that is number one. Second important is Prinzmetal angina, right? Second important is the Prinzmetal angina, and third important is unstable angina, right? So these three, they form the spectrum of the ischemic heart diseases. Whereas if you take infarction, so in case of infarction, we have the NSTEMI and as well as the STEMI, right? NSTEMI and as well as the STEMI. Now, so you take this last three, they form acute coronary syndrome, right? They form acute coronary syndrome. Now, if you see the difference between ischemic heart disease and as well as the infarction, very important, how will you differentiate these two is mainly by the cardiac biomarkers. Okay, so it is the cardiac biomarkers that will be positive in case of the NSTEMI and as well as the ST elevation MI, whereas the cardiac biomarkers, they are negative in case of the stable angina, Prinzmetal angina and as well as the unstable angina, right? So it is the cardiac biomarkers which will differentiate these two, right? And what are these cardiac biomarkers? These cardiac biomarkers, they are mainly number one, CKMB, and next important is the troponin. So these two are the important cardiac biomarkers. Now, when do they appear in the blood? They appear in the blood 2 to 4 hours, right? 2 to 4 hours after the myocardial injury, right? Or whenever the individual had an NSTEMI or STEMI, after 2 to 4 hours, they start appearing in the blood, right? So for how long they remain within the blood? If you take CKMB, that will remain for nearly around 72 hours. Whereas if you take the troponin, troponin will remain in the blood for nearly around 10 to 14 days. Right? Troponin will remain in the blood for nearly around 10 to 14 days. Okay. So these are the important biomarkers that will be positive in case of the NSTEMI, but negative in case of the stable angina. So these are the best methods by which The cardiac biomarker is the best method by which you will be able to differentiate. Now, what about the other options? You take the ECG. ECG, in case of stable angina, you can have non-specific STT changes. Right? You will have non-specific STT changes. So, what do you mean by this word non-specific STT changes? ST segment depression and T wave inversion may or may not be there in case of the stable angina. Whereas even in case of non-ST elevation MI also, you will have the ST segment depression and as well as T wave inversion. So the ST segment depression and T wave inversion can be there in both stable and as well as the NSTEMI. Whereas transthoracic echocardiography, in stable angina also you will have mild LV dysfunction, and in NSTEMI also there can be mild LV dysfunction, right? But so your transthoracic echocardiography is not an ideal investigation to differentiate these two. And Muga scan, this is only useful for assessment of the ejection fraction, but by your Muga scan you will not be able to differentiate the stable angina from non-ST elevation MI. So it is your cardiac biomarkers which will help us to differentiate between the stable angina and as well as the NSTEMI, right? Next, coming to the next question. All are used for the secondary prevention of the MI except. Options are the aspirin, statin, beta blockers and as well as the warfarin. Now, if you take in case of the myocardial infarction, just now I was discussing in case of the acute coronary syndrome. What are the clinical entities which comes under acute coronary syndrome? That is unstable angina, NSTEMI and as well as the STEMI. So they come under acute coronary syndrome, and in case of acute coronary syndrome we give loading doses of the aspirin, right? That is 325 milligrams of the aspirin. Then we give clopidogrel, and this clopidogrel you need to give 300 milligrams, and then statin you need to give, that is atorvastatin. And the dosage of the atorvastatin that we give is the 80 milligrams. If you are giving rosuvastatin, then you give 40 milligrams. And apart from clopidogrel, the other drug that can be given is, like, we get a trade name called Brilinta, right? So that is another important molecule that can be given in the place of the clopidogrel, right? Now, after giving these drugs, depending upon the type of the entity, that is whether it is STEMI or NSTEMI or unstable angina, the treatment varies. That already I have discussed. But what are the drugs that you will be giving for secondary prevention? The drugs definitely that you need to give is DAPT. That is dual antiplatelet therapy should be given in case of the acute coronary syndrome. Now, what will be this dual antiplatelet therapy containing? That is aspirin plus clopidogrel. Right, aspirin plus clopidogrel. And the drug, the trade name that Brilinta, what I was telling, was ticagrelor. In the place of clopidogrel, you can also give ticagrelor. But if at all, if you are giving ticagrelor, you need to give 180 milligrams of ticagrelor, right? Next, now this dual antiplatelet therapy, this has to be given for nearly around 1 year, right? Why? Mainly to prevent mainly to see that there will be a secondary prevention. And next is, after 1 year, you need to convert that into a single antiplatelet. Right? A single antiplatelet is required after 1 year, right? Now, the point very important is, what are the other drugs apart from antiplatelets and as well as statins? What are the other drugs that you need to give? The other drugs that you need to give is beta blockers. So beta blockers, basically what they will do is they will reduce the heart rate, and thereby they will reduce myocardial oxygen demand in a patient with the ischemic heart disease. So beta blockers, statins, aspirin we give for secondary prevention. But the drug that we don't give is the warfarin. Warfarin is not required as a secondary prevention in case of the MI. Now, apart from these drugs, the other drugs that we give, so one is your statins, then dual antiplatelet therapy and beta blockers. Then the other drugs that we need to give is the anti-anginal drugs. So the anti-anginal drugs that we give is nitrates. Right? The anti-anginal drugs that we give is nitrates. Okay. And isosorbide mononitrate or dinitrate you need to give. We have one more drug which is given in the treatment of the chronic angina, that is ranolazine. Right, that is ranolazine. So ranolazine is another important anti-anginal drug which is given in the treatment of the chronic angina. So these are the drugs which we give as a part of the treatment for the MI and as well as the secondary prevention. Next question. All are true about the hypertrophic cardiomyopathy except systolic dysfunction, then concentric hypertrophy, diastolic dysfunction, double apical impulse. Okay, if you take hypertrophic cardiomyopathy, it is a form of cardiomyopathy which is inherited, and the type of inheritance is the autosomal dominant type of inheritance. And the gene or the protein which is being defective are the beta myosin gene. Right, so beta myosin gene is being defective, right? And one more important gene is NYHA gene that is being defective in case of the hypertrophic cardiomyopathy. Then we have troponin I and then myosin binding protein C. Right, myosin binding protein C. So these are the proteins which are being defective in cases of the hypertrophic cardiomyopathy, and more than 100 genes are being defective. Right, out of these genes, they constitute 70 to 80% of the causes for the hypertrophic cardiomyopathy. And among all the types of cardiomyopathies, like you have dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. Hypertrophic cardiomyopathy, it is the disorder which is characterized by diastolic dysfunction, and these patients, they will have heart failure with preserved ejection fraction. Right, they'll have heart failure with preserved ejection fraction. That is what you will have in case of the hypertrophic cardiomyopathy, and you don't have the systolic dysfunction. And these patients with hypertrophic cardiomyopathy, like what should be the increase in the thickness of the myocardium to call it as hypertrophic cardiomyopathy is the increase in the thickness of the LV should be more than 1.5 centimeters. And this increase in the thickness of the myocardium, this will be either in the septum, right, or within the apex. Now, if there is increase in the thickness of the septum, what will be the shape of the LV? That is a banana shaped LV, right? And if there is increase in the thickness at the apex, then the shape of the LV, we describe it as the ace of spades. Right, we describe it as the ace of spades, right? And one more important point is the hypertrophy that you will have is the concentric hypertrophy causing diastolic dysfunction. And most of these patients with hypertrophic cardiomyopathy, they are asymptomatic. Most of them, they directly present with sudden cardiac death on exertion. Right, they directly present with sudden cardiac death on exertion. And if at all, if they are symptomatic, what will be the most common symptom? So if at all, if they are symptomatic, the most common symptom will be the development of the dyspnea. Then on examination, what is that you will have is pulsus bispherians. Right, on examination you will have pulsus bispherians. And if you take the carotid, it will be a double carotid upstroke. Right, it will be a double carotid upstroke. And how will be the apical impulse? The apical impulse will be a double apical impulse. Right, it will be a double apical impulse. And so why is the double apical impulses? In this phase of the systole itself, the ventricle will try to contract for 2 times strongly, because in the mid part of the systole there will be an obstruction to the ventricular contraction. To overcome the obstruction, the ventricle will try to give a second contraction very strongly during the same phase of systole. That is the reason why we call it as the double apical impulse, right? And one more important thing is these patients on auscultation along with S1 and S2, they will also have the S4. Additional heart sound will be there. And the type of murmur that you will have is the ejection systolic murmur, which is also called mid-systolic murmur. Then what is the first line investigation is we do a 2D echo for diagnosing the hypertrophic obstructive cardiomyopathy, right? And this hypertrophic obstructive cardiomyopathy, you will have banana shaped LV on the echocardiography, and you will have heart failure with preserved ejection fraction, where ejection fraction will be more than 55%. Now, if you take the treatment, what is the drug of choice? Drug of choice in these patients will be the beta blockers. And what are the alternative drugs if the place where you cannot give beta blockers is calcium channel blockers? And there are certain drugs which are contraindicated in patients with the hypertrophic obstructive cardiomyopathy. What are the drugs which are contraindicated? The drugs which are contraindicated are digoxin, then epinephrine, then diuretics, and then nitrates. So these are the drugs which are contraindicated in patients with the hypertrophic obstructive cardiomyopathy. So in short, these are the important points about the HOCM. And please remember, in HOCM you will not have systolic dysfunction. What you will have is the diastolic dysfunction, right? Next question. Now, inability to carry out any physical activity without discomfort comes under NYHA class 1, 2, 3 and as well as 4. Now, so the NYHA classification, what is it called? Newark Heart Association classification, which is used for assessment of severity of dyspnea, fatigue, palpitations in patients with the left ventricular failure. So in patients with left ventricular failure, to assess the severity of the dyspnea, what we use is NYHA classification. Now, inability to carry out any physical activity without discomfort, it comes under NYHA class 4. Whereas, if you take in case of the NYHA class 1, as such, there is no limitation of the physical activity, right? Whenever the individual is doing the ordinary physical activity, he is able to do comfortably. But whenever he does the activities upon exertion, right, there will be dyspnea on exertion. So exertional activities is the one which makes the individual being symptomatic. Whereas in case of the NYHA class 2, there will be a slight limitation of the physical activity. These patients, they are comfortable at rest, but right, they are comfortable at rest. Upon exertion, they will be having the discomfort. Okay, or upon doing the ordinary activity also, they will be having the discomfort, right? Whereas in class 3 or NYHA class 3, there is marked limitation of the activity, right? And whenever the individual does less than ordinary activity also, they will be having the dyspnea. Whereas the NYHA class 4, these individuals, they will be having the dyspnea at rest. That is what is nothing but inability to carry out any physical activity without discomfort. That is NYHA class 4. So the answer is fourth option. Next question. And one more point you need to remember is, see, your dyspnea, it is a feature of the left ventricular failure. Now, what are all the other features that or clinical features that you will have in case of left ventricular failure is, number one, they will be having fatigue. Why? That is because of decrease in cardiac output. And the next important clinical manifestation is the dyspnea, right? And on examination, right, on examination, they will be having significant hypotension. Why there is significant hypotension? That is because of decrease in the cardiac output, right? That is because of decrease in the cardiac output. And one more important feature that you will have is pulsus alternans, right? Pulsus alternans. But this pulsus alternans will be there only in cases of severe left ventricular failure. There will be pulsus alternans, right? And along with S1 and as well as S2, there will be S3 and S4 in patients with severe left ventricular failure. And whenever there is development of pulmonary edema, these patients, they will have bilateral crepes, right? They'll be having bilateral crepitations upon the examination. So these are the features that you will have in patients with left ventricular failure. And next important question, a patient with congestive heart failure with left ventricular ejection fraction less than 40% should be given ACE inhibitors plus beta blockers, ACE inhibitors plus furosemide, ACE inhibitors plus calcium channel blockers, ACE inhibitors plus the angiotensin receptor blockers. Now, so this comes under HFrEF, right? That is heart failure with reduced ejection fraction, where the ejection fraction of the individual, it is less than 40%. Now, what are the various etiologies that will be causing HFrEF is, one of the very important etiology is the coronary artery disease. That is nothing but your ischemic heart disease, that is your MI, or like the NSTEMI, STEMI, or your stable angina, okay? And one more important etiology that will be causing the HFrEF is MR, AR, and as well as even the TR. So these are the etiologies that will be causing the HFrEF, where there is heart failure with reduced ejection fraction. And the another important etiology which can cause the HFrEF is, we have a parasitic infection that is called as the Chagas disease, and then dilated cardiomyopathy. So these are the important etiologies that will be causing HFrEF. And in patients with HFrEF, the important drugs are beta blockers. Okay, in acute cases of left ventricular failure, there will be pulmonary edema, where you should be giving furosemide, right? In acute left ventricular failure, you should give only furosemide. We don't give the ACE inhibitors or beta blockers. So only it is when you clear the pulmonary edema, then the drugs that you need to give in these patients will be the beta blockers and as well as the ACE inhibitors, right? Beta blockers and as well as ACE inhibitors. So now these beta blockers and ACE inhibitors, they have been found, right? They have been found to reduce the mortality in patients with the left ventricular failure. Now, whenever you are giving these beta blockers, right? Whenever you are giving these beta blockers, the beta blockers that need to be given is, right? Please remember these beta blockers. That is bisoprolol, then metoprolol, then carvedilol. Okay, so these are the beta blockers that need to be given. And whenever you are giving these beta blockers also, these beta blockers, they have to be given at low dose, and then gradually you need to step up the dose, right? Gradually you need to step up the dose. And next important point is, these beta blockers, they have to be given with extreme caution in class 3 and as well as class 4 NYHA. They have to be given with extreme caution in class 3 and as well as the class 4 NYHA. And please remember, these beta blockers are completely avoided in patients with acute left ventricular failure, or when the patient is in a state of decompensated heart failure causing acute pulmonary edema. Beta blockers should never be given, right? So that's a very, very important point. So when the edema is reduced, that is the point when you need to give the ACE inhibitors plus beta blockers, which will reduce the mortality in patients with the HFrEF. So if you see the next question, in a patient with chronic congestive cardiac failure, all of the following drugs prolong the survival except. The options are metoprolol, carvedilol, enalapril, digoxin. So in acute phase of the congestive heart failure, we give oxygen supplementation, furosemide. Then we put the patient on the non-invasive ventilator if the oxygen saturation is not maintained with the oxygen mask itself. Then we need to give vasodilators, that is nitroglycerin or nesritide. And if the individual is in cardiogenic shock, you need to put the patient on norepinephrine or dobutamine. Now, but what are the drugs which will prolong the survival of the individual? So the drugs which will prolong the survival of the individual are, number 1, beta blockers. Number 2, the ACE inhibitors. And if the individual is not able to tolerate the ACE inhibitors because of the dry cough, the alternative drugs that can be given is the aldosterone antagonists, right? The alternative drugs will be the aldosterone antagonist. And the third important group of drug is, So if the individual is not able to tolerate the ACE inhibitors, then you need to give angiotensin receptor blockers. Then the next important group of drug will be aldosterone antagonists. So the example of this aldosterone antagonist will be spironolactone or eplerenone. Now recently the new molecule which have come up in reducing the mortality and prolonging the survival of an individual with the heart failure is SGLT2 inhibitors. Right? SGLT2 inhibitors. So these are the drugs which will prolong the survival of the individual. And what are the examples of these SGLT2 inhibitors? Canagliflozin, dapagliflozin, and as well as the empagliflozin. Basically, these drugs are given in the treatment of type 2 diabetes mellitus because they inhibit the SGLT2 channel at the level of the proximal convoluted tubule in the kidney and thereby inhibiting the glucose absorption, reducing the glucose levels in the body. So SGLT2 inhibitors, they are also not only used in the type 2 diabetes mellitus, but they are also used in the heart failure to reduce the mortality and prolong the survival. So among the options which has been given to you, the one is accept. So that is digoxin will not prolong the survival of the individual. Where do we give digoxin in patients with congestive heart failure is if the patient is having congestive heart failure, along with that, if the individual is in a state of atrial fibrillation, that is the point when we give digoxin, right? Next question. Continuous murmur is present in patent ductus arteriosus, aortic stenosis with aortic regurgitation, mitral stenosis, then ventricular septal defect with the aortic regurgitation. Now, the continuous murmur, right, it is present in case of the patent ductus arteriosus. Now, what is another name for the continuous murmur that we see in case of the patent ductus arteriosus is, this is also called as the Gibson's murmur. Right, this is also called as the Gibson's murmur. And this Gibson's murmur, where is it heard? This Gibson's murmur, it is heard in the first left intercostal space, parasternal line. Right, first left intercostal space, parasternal line. This is the place where you will listen the Gibson's murmur in individual with the patent ductus arteriosus. And what are the other conditions where you will have the continuous murmur is in patients with the AV fistula, right? And this particular AV fistula, it can be a peripheral AV fistula or the coronary AV fistula. And the other important condition is the RSOV, that is ruptured sinus of Valsalva. You can have the presence of the continuous murmur. Next is in case of the truncus arteriosus, you can have the presence of the continuous murmur. Now, apart from these conditions, you also have in pregnancy, and that we call it as the mammary souffle, right? In case of mammary souffle, you need to auscultate over the mammary gland during the pregnancy. Due to increased blood flow through the mammary arteries, there can be presence of the continuous murmur. And in case of children, in the right supraclavicular area, you can have a continuous murmur, and that we call it as the venous hum, right? That we call it as the venous hum. So these are the conditions where you have the presence of the continuous murmur. Whereas you take the other options. So if you take the second option, what is the murmur that you have in case of AS with AR? So in case of the aortic stenosis, the murmur will be ejection systolic murmur, and as a part of the aortic regurgitation, you will have early diastolic murmur. So it will be mid systolic murmur or ejection systolic murmur plus early diastolic murmur, what you will have in case of AS with AR. Whereas in mitral stenosis, the murmur that you will have is the mid diastolic murmur. Whereas in case of VSD, it is pansystolic murmur, and as a part of the AR, you will have the early diastolic murmur. So this will be the murmurs in various other options, but in PDA, you will have continuous murmur. And what exactly you understand by this word continuous murmur? Continuous murmur is that which is heard from the starting of S1 and it peaks around S2, and it is also heard up to S1. That is what is nothing but your continuous murmur, right? Next question. During the cardiac cycle, the opening of the aortic valve takes place at beginning of the systole, end of the isovolumetric contraction, end of diastole, end of diastasis. So if you take the opening of the aortic valve, that is nothing but semilunar valve, this will happen during the isovolumetric contraction phase. So during isovolumetric contraction phase of the systole, two events happen. One is there will be closing of the semilunar valves. I'm sorry, please correct it. So there will be two events that will be taking place. One is the closing of the AV valves, that is mitral, and as well as tricuspid valve. And during the isovolumetric contraction phase, there will be also opening of, right? There will be also opening of the semilunar valves. But you have to understand when is that this opening of the semilunar valves occur. That will be during the end of the isovolumetric contraction. So at the end of isovolumetric contraction, you have the opening of the aortic valve and as well as the pulmonary valve. And it is not during the beginning of the systole, right? Now, what exactly is your end of diastolic phase? The end of diastole is the point when there will be atrial contraction, right? There will be atrial contraction and second rapid filling phase of the ventricle, right? Second rapid filling phase of the ventricle, right? And it is not the end of diastasis, right? Which one? The opening of the aortic valve is not during the end of diastasis. What is diastasis? It is also the phase in the diastole, right? So in diastole, you have the protodiastole, isovolumetric relaxation phase, first rapid filling phase, diastasis, and second rapid filling phase. And that second rapid filling phase is nothing but the end of diastole, right? Now, coming on to the next question. Now, in this cardiac cycle, you need to know like the correlation with the heart sounds. So during isovolumetric contraction phase, you will be listening the first heart sound, right? And during isovolumetric relaxation phase, or some books give even during protodiastole, you will have the second heart sound, right? And in the first rapid filling phase, right? In the first rapid filling phase, you will have the third heart sound. Whereas during second rapid filling phase, you will have the fourth heart sound. Okay. So these are the four important heart sounds correlating with the cardiac cycle. Next question. Which of the following drugs is not given in the dilated cardiomyopathy? Beta blockers, calcium channel blockers, spironolactone, and then the ACE inhibitors. So what exactly is your dilated cardiomyopathy? Dilated cardiomyopathy is the condition which is characterized by heart failure with reduced ejection fraction. That is what is your dilated cardiomyopathy, where you have heart failure with reduced ejection fraction. Now, when an individual is having a heart failure with reduced ejection fraction, it means the ejection fraction is less than 40%, and the drug that you should not give in case of the dilated cardiomyopathy will be the calcium channel blockers. So calcium channel blockers, they are avoided in patients with heart failure with reduced ejection fraction, whereas beta blockers, aldosterone antagonists like spironolactone, and ACE inhibitors, they improve the survival and they reduce the mortality in patients with the dilated cardiomyopathy. So some quick points about the dilated cardiomyopathy. So dilated cardiomyopathy, you will have heart failure with reduced ejection fraction, and the important toxin that will be causing the dilated cardiomyopathy will be the alcohol. Alcohol is the important toxin. Then apart from that, we have many other the chemotherapeutic drugs and as well as drugs of abuse like cocaine, right? And immunosuppressant drugs like cyclophosphamide. So these are the drugs which will be causing the dilated cardiomyopathy. And in patients with dilated cardiomyopathy, the important clinical presentation will be in the form of dyspnea. And we also have some endocrine disorders that will be causing dilated cardiomyopathy. And the endocrine disorders causing dilated cardiomyopathy will be diabetes mellitus and then thyroid disorders. What are these thyroid disorders? That includes hypothyroidism and as well as the hyperthyroidism. These are the thyroid disorders that will be causing the dilated cardiomyopathy. And hematological conditions which will be causing dilated cardiomyopathy will be sickle cell anemia. And in case of neurological conditions, we have muscular dystrophies and as well as Friedreich's ataxia that will be causing the dilated cardiomyopathy, right? And apart from this, we also have some inflammatory conditions, that is autoimmune conditions like systemic lupus erythematosus, then systemic sclerosis. These are the conditions where you can have the presence of the dilated cardiomyopathy. Now, in patients with dilated cardiomyopathy, on examination, like how will be the type of the apical impulse? The apical impulse will be diffuse and as well as the hypokinetic type of the apical impulse that you will have in case of dilated cardiomyopathy. And in dilated cardiomyopathy, along with first and second heart sound, when the individual goes into a heart failure, they'll also have S3 and as well as S4. And there will be functional MR and as well as the functional TR. Then what will be the first line investigation in case of dilated cardiomyopathy? The first line investigation will be the two-dimensional echocardiography. That will be the first line investigation. And how do you treat these patients with dilated cardiomyopathy? When the individual with dilated cardiomyopathy, when they'll end up in acute left ventricular failure, they will be requiring the treatment with furosemide, right? They will be requiring the treatment with the furosemide, right? And the next important group of drugs which are required are the ACE inhibitors and as well as angiotensin receptor blockers. And then we have the aldosterone antagonists. They improve the survival of the individual. But the drugs which should be avoided will be the calcium channel blockers. And recently, the new molecule which has come up in the treatment of dilated cardiomyopathy to improve the ejection fraction is, we have what is called ARNI, that is angiotensin receptor blocker neprilysin inhibitor. Now, what is this angiotensin receptor blocker? The example is valsartan, right? And the neprilysin inhibitor is nothing but the sacubitril. Okay, so valsartan plus sacubitril. So this is what is nothing but your ARNI, which is given in the treatment of dilated cardiomyopathy, which helps in improving the ejection fraction of the individual. So this is about the dilated cardiomyopathy, right? The drugs that should be avoided is calcium channel blockers. Next question. Which of the following can differentiate between the cardiac tamponade and as well as the tension pneumothorax? The options are jugular venous pressure, pulse volume, breath sounds, and as well as the pulse rate. Now, in patients with the tension pneumothorax and as well as cardiac tamponade, in both of them, the pressure within the mediastinum is increased, right? Now, as the pressure within the mediastinum is increased, the JVP will be increased because the venous return will not be adequate. And in both of them, you have decrease in the pulse volume. Whether you take cardiac tamponade and tension pneumothorax, because the mediastinal pressure is increased, the venous return is decreasing, the cardiac output decreases, the pulse volume decreases, right? And the characteristic pulse that you will have is pulsus paradoxus, right? Pulsus paradoxus. Now, the very important differentiating point between cardiac tamponade and tension pneumothorax is the breath sounds. Okay. Now, if you take the breath sounds, please remember, in case of the cardiac tamponade, the breath sounds are being heard, whereas in case of the pneumothorax, the breath sounds, they are absent. Right? In pneumothorax, the breath sounds, they are absent. Right? That is the differentiating point between the cardiac tamponade and as well as the tension pneumothorax. Whereas the pulse rate, if you see, there will be tachycardia. Right? There will be tachycardia in both of them. That will be like common between the cardiac tamponade and as well as the tension pneumothorax. It is only the breath sounds which will help us to differentiate between the cardiac tamponade and the pneumothorax. Right? So the answer is C. Now, some quick points about the cardiac tamponade, which is a very, very important condition. So basically what is a cardiac tamponade is, it is abrupt accumulation of the fluid in the pericardial space. That is what is called as cardiac tamponade. Now, what is very important thing that you need to remember about the cardiac tamponade is a terminology called as the Beck's triad. Now, what is this Beck's triad? It is the triad where the individual will have the hypotension, right? And there will be jugular venous distension, and there will be muffled heart sounds, right? There will be muffled heart sounds. So these these three, they constitute the Beck's triad, right? And in patients with Beck's triad, in cardiac tamponade, already we have discussed, it is the pulsus paradoxus. And please remember, the JVP will be elevated, and the elevated JVP, the Kussmaul sign will be absent, right? The Kussmaul sign will be absent. And the abnormal waves that you have in patients with the cardiac tamponade is, you will have deep X wave, right? You will have deep X wave. Whereas if you take the Y wave, it is absent, right? And next is the ECG. So ECG will show you, right? ECG will show you that there is presence of the electrical alternance, and the investigation of choice will be the 2D echo. So 2D echo, right, it will show you that there will be diastolic collapse of the ventricle, right? There will be diastolic collapse of the ventricle. And what is the treatment of choice? The treatment of choice will be pericardiocentesis. The treatment of choice will be pericardiocentesis, and this pericardiocentesis, it should be done through a subxiphoid approach. So this is about the cardiac tamponade, right? Next question. The treatment of acute pulmonary edema includes all of the following except morphine, digoxin, furosemide, and positive ventilation. Just now I was discussing. So the drug that is not required in the treatment of acute pulmonary edema will be the digoxin. Now, what is the purpose of giving the morphine? Morphine is the one which will reduce the anxiety in patients with the acute pulmonary edema, and it will also reduce the sympathetic activity. Right, it will also reduce the sympathetic activity in patients with the acute pulmonary edema. So for that reason we give the morphine. And furosemide, that is to mainly flush out the pulmonary edema, that is to flush out the fluid. And positive ventilation is required to maintain the oxygen saturation, and the oxygen saturation should be maintained of more than 95%. And not only that, the positive ventilation is the one which is required for flushing out of the fluid from the alveoli into the capillaries, right? So that is about the positive ventilation. Next question. Standard ECG leads are unable to detect left ventricular hypertrophy, right bundle branch block, right ventricular infarcts, then the arrhythmias. So please remember, the standard ECG leads can detect the LVH. And for diagnosing LVH, we have a criteria, and the name of the criteria is the Sokolov-Lyon criteria. Now, according to this Sokolov-Lyon criteria, the depth of S wave in V1 plus the amplitude of R wave in V6, this should be more than 35 mm, right? This is what is called the Sokolov-Lyon criteria, and that can be detected by the standard ECG leads. Whereas if you take the right bundle branch block, even that can be diagnosed by the standard ECG leads. So in case of the right bundle branch block, so you will have M-shaped R wave, right? You will have M-shaped R wave in V1, then W-shaped S wave in V6, right? W-shaped S wave in V6. So, and very important, in any bundle branch block you take, either you take right bundle branch block or left bundle branch block, you will have wide QRS complex. That is the very important part of the discussion. And the arrhythmias, yes, even you can diagnose arrhythmias on the standard ECG lead. You can diagnose atrial fibrillation, you can diagnose atrial flutter, you can diagnose atrial ectopic, and you will also be able to diagnose the ventricular arrhythmias, that is VT and VF, and even supraventricular tachycardias as well, right? But right ventricular infarct, it is not able to be detected easily on the standard ECG leads. Now, in order to diagnose the right ventricular infarct, then what is that you need to do? So what is that you need to do is, the leads, instead of placing on the left side, the leads you have to place it on the right side. So you have V1R, then you have V2R, then V3R, followed by that V4, V5, and then V6R. Okay, so you need to place the leads on the right side in case of right ventricular infarct to pick up the right ventricular infarction. Next question. In LVH, yes, this is what I was discussing in the previous question. In LVH, SV1 plus RV6, it should be more than 25 mm, 30 mm, 35 mm, and as well as the 40 mm. So please remember, it should be 35 mm. And what is the name of the criteria? Sokolov-Lyon criteria, right? So we can diagnose LVH and we can also diagnose the RVH as well. Now, what is the criteria for the RVH? The criteria for RVH is the amplitude of the R wave in V1, it should be more than 6 mm. Right, the amplitude of the R wave in V1, it should be more than 6 mm, whereas the depth of S wave in V6, it should be more than 3 mm. Right, the depth of S wave in V6, it should be more than 3 mm. So that is what you will observe in case of the right ventricular hypertrophy, right? Next question. In which of the following drugs is to be immediately stopped in a patient of diabetes with hypertension, severe septicemia, serum creatinine level of 5.7 milligrams? The options are metoprolol, linagliptin, metformin, and then the insulin. So this patient is having the creatinine of 5.7, right? The individual is in a state of the renal failure. So the drug that need to be avoided when the individual is in a state of renal failure is the metformin. Okay, so metformin, it should be reduced or even stopped if the estimated GFR is less than 30%, and if the serum creatinine value, if it is like more than 2 to 2.5 milligrams percentage, you should avoid giving metformin. Now, what happens when you give metformin in case of renal failure is, one of the very important adverse effect with metformin is lactic acidosis. So there will be precipitation of lactic acidosis. Right, there will be precipitation of the lactic acidosis whenever we give metformin in case of renal failure. So that is the reason why metformin should not be given. Whereas metoprolol, yes, that should be given in patients with the hypertension, right, and as well as diabetes. It doesn't have much of the contraindication in case of the renal failure. Linagliptin, right, what is this linagliptin? Gliptins, they are DPP4 inhibitors which are given in the treatment of the diabetes mellitus. And this linagliptin is the drug. L for linagliptin, L for liver, it is metabolized in the liver and it is excreted through the bile. So that is the reason why it can be comfortably given even in patients with the renal failure. And insulin is the drug of choice for the treatment of the diabetes mellitus in case of renal failure, right? So the drug that you should not give is metformin. Okay, next question. Now, which of the following is known as the type 1A diabetes mellitus? So immune mediated type 1, idiopathic type 1, LADA, then maturity onset diabetes of young. So if you take the diabetes mellitus, we have type 1 diabetes mellitus, then type 2 diabetes mellitus, then we have the other causes for the development of diabetes mellitus, and then the diabetes mellitus in pregnancy, that is gestational diabetes mellitus. In case of type 1 diabetes mellitus, the important concept is there will be beta cell destruction, right? There will be beta cell destruction. Now, this particular beta cell destruction, why does it occur? It is immune mediated beta cell destruction. Right? It is the immune mediated beta cell destruction, right? And this immune mediated beta cell destruction, we use the term type 1A. And we also have, so your immune mediated is type 1A. Whereas you also have type 1B. Type 1B, it is nothing but, it is idiopathic mediated diabetes mellitus. Right, it is idiopathic mediated diabetes mellitus, that is your type 1B. Right, so this will be type 1B. And that is about type 1 diabetes mellitus. Whereas if you take type 2 diabetes mellitus, it is a disorder where the individual will have the insulin resistance. Right, where the individual will have the insulin resistance on the target organs. What are the target organs? The target organs include liver, adipose tissue, and as well as the skeletal muscle. These three are the important target organs for the insulin, and there will be insulin resistance in case of type 2 diabetes mellitus. Whereas if you take the other forms of diabetes mellitus, in other forms of diabetes mellitus, we have certain drugs which will be causing hyperglycemia. The very important group of drugs are the steroids, right? And then we also have some endocrine conditions which will be causing diabetes mellitus, hyperglycemia apart from diabetes. The other endocrine conditions which will be causing the hyperglycemia will be, number 1, glucagonoma. Right, glucagonoma. This is one important condition. Now, apart from glucagonoma, the conditions where there is increase in growth hormone, that is acromegaly. The other conditions are the conditions where there is increase in epinephrine and as well as norepinephrine, that is pheochromocytoma, right? You will have the hyperglycemia. And the next important condition is in patients with hyperparathyroidism, there can be increase in the glucose levels, and there can also be increase in glucose levels in patients with hyperthyroidism. So these are the endocrine conditions which will be causing the hyperglycemia, right? Now, apart from this, we have LADA, right? Your third option is your LADA, that is latent autoimmune diabetes of adults. Now, in case of LADA, right, there will be what is LADA? That is latent autoimmune diabetes of adults. Actually, immune mediated beta cell destruction, that is type 1 diabetes mellitus, it is usually seen in children of age less than 20 years. Then what exactly is your LADA? LADA, it is latent autoimmune diabetes of adults where there is antibody production causing the beta cells in the adults, right? And this LADA, it is a rare form of diabetes mellitus. We also call this LADA as the type 1.5 diabetes mellitus, okay? And in case of LADA, what are the antibodies? The antibodies are the anti-GAD antibodies, right? And then islet cell antibodies, okay? Anti-GAD antibodies and as well as the islet cell antibodies. Now, in case of LADA, these antibodies, they destroy the beta cells and the insulin level will be reduced. So, the treatment that you need to give in these patients is, we need to supplement insulin in this patient, right? We need to supplement insulin in this patient. So that is what is the treatment in case of LADA, because the beta cells are being destroyed. So that finishes your LADA. And gestational diabetes mellitus, that will be in pregnancy. And one more important form in diabetes mellitus will be MODY, that is maturity onset diabetes of young. I'll be discussing that subsequently, right? Next question. Yeah, this MODY, I'll be discussing that in the next question, in subsequent questions. Yes, zinc transporter 8 antibody is seen in Hashimoto's thyroiditis, hypoparathyroidism, type 1 diabetes mellitus, type A insulin resistance. Now, in case of type 1 diabetes mellitus, it is the immune mediated destruction of the beta cells. Now, what are the antibodies in case of the type 1 diabetes mellitus? The antibodies in case of type 1 diabetes mellitus will be number 1, islet cell antibody, that is number 1. Number 2, GAD65, that is glutamic acid decarboxylase antibody. Then next important is insulin islet cell antibody, and next is the zinc transporter 8, right? Zinc transporter 8, and then tyrosine phosphatase. Right, tyrosine phosphatase. So these are the antibodies that are formed in type 1 diabetes mellitus causing the beta cell destruction. So these are the autoimmune markers in case of the type 1 diabetes mellitus. And whereas Hashimoto's thyroiditis, this is also an autoimmune condition, but the antibodies that you have here is anti-TPO antibodies. The antibodies that you will have is anti-TPO antibodies. Next question. HNF1 alpha defect is seen in MODY 2, MODY 3, MODY 4 and then MODY 5. So this MODY, that is maturity onset diabetes of young, it is usually observed in age group 20 to 30 years, right? Between the age group of 20 to 30 years, you observe this MODY, that is maturity onset diabetes of young. And second important point is, in case of MODY, please remember that in MODY, the beta cell dysfunction will be there. It is not beta cell destruction, it is just only beta cell dysfunction. And in patients with MODY, the BMI will be absolutely normal, right? And these patients, they never develop diabetic ketoacidosis, and there should be a very strong genetic inheritance, right? There should be a very strong genetic inheritance. So a very strong genetic inheritance is that where minimum 2 members in the family, that is not only father, even grandfather also should be diabetic. So 2 generations should be diabetic in case of the MODY, that is maturity onset diabetes of young. And in case of MODY, where there is beta cell dysfunction, what is the drug of choice? The drug of choice in case of MODY will be low dose sulfonylureas, right? It will be low dose sulfonylureas, right? And this particular low dose sulfonylureas, what we give, that is glimepiride. That is glimepiride. So that is what we give to stimulate the beta cells, and there will be release of the insulin from the beta cell dysfunction. So, and now if you take this MODY, we have the MODY's type, that is maturity onset diabetes of young, that is MODY 1 to 6. So in case of MODY 1 to 6, the important form of MODY will be MODY 3. Now in case of MODY 3, which is the most common type of MODY, the gene that is being mutated, that will be the HNF1 alpha. So this is about the maturity onset diabetes of young. Next question. which of the following diabetes has impaired glucose induced secretion of insulin with preserved beta cell mass? That is what I was discussing now. MODY, Wolfram syndrome, type 1 diabetes mellitus, LADA. Now in case of the type 1 diabetes mellitus, beta cell destruction is there. LADA, there is beta cell destruction. Whereas in case of MODY, that is maturity onset diabetes of young, you have beta cell dysfunction where there is a preserved beta cell mass, right? Where there is a preserved beta cell mass. Whereas you take in case of the Wolfram syndrome. What exactly is this Wolfram syndrome? The another name for Wolfram syndrome is, this is also called as the Dilated syndrome. Right, this is also called as the Dilated syndrome. DI stands for diabetes insipidus. DM stands for diabetes mellitus, right, where there will be destruction of the beta cells. And OA stands for the optic atrophy. And the word D will be deafness. Right, the word D will be deafness. Okay, so and Wolfram syndrome, you have beta cell destruction. Whereas in case of MODY, maturity onset diabetes of young, so it is impaired glucose induced insulin secretion with preserved beta cell mass, for which we are giving the sulfonylureas as the drug of choice. Right, next question. Necrobiosis lipoidica diabeticorum is most marked on forearms, face, pretibial, sole of the foot. So if you take necrobiosis lipoidica diabeticorum, it is the cutaneous manifestation, right? It is the cutaneous manifestation that you observe in patients with the diabetes mellitus. And in case of the necrobiosis lipoidica diabeticorum, where exactly is this cutaneous manifestation? So you have orange brown discoloration of the skin, right? You have orange brown discoloration of the skin, and that will be there over the tibia, right? That will be there over the tibia. And what is another important dermatological manifestation in diabetes mellitus is, the another important dermatological manifestation apart from necrobiosis lipoidica diabeticorum, we have acanthosis nigricans, right? We have acanthosis nigricans. So acanthosis nigricans is another important dermatological manifestation where you have the presence of a dark velvety skin, right? Where you have the presence of a dark velvety skin, and usually over the nape of the neck, right? Usually over the nape of the neck. So the answer here is the pretibial area, you have the presence of the necrobiosis lipoidica diabeticorum, right? Next question. Yeah, so this is the presentation of the necrobiosis lipoidica diabeticorum, right? Now the next question is, the causes of diffuse hyperpigmentation include the following except busulfan administration, Nelson syndrome, Addison's disease, Hermansky-Pudlak syndrome. So all these conditions, busulfan administration will cause hyperpigmentation, Nelson will cause hyperpigmentation, Addison's will also cause hyperpigmentation. Whereas if you take the Hermansky-Pudlak syndrome, so this is a form of hypoalbinism. I mean, this is a form of albinism where there is hypopigmentation. So terminology that we use for this is oculocutaneous albinism. Right, oculocutaneous albinism, and this is what is called as the Hermansky-Pudlak syndrome. So in these individuals, there will be decreased pigmentation. Right, in these individuals, there will be decreased pigmentation. And the type of disorder, if you observe here, it is an autosomal recessive type of the disorder. And these patients with Hermansky-Pudlak syndrome, there will also be a bleeding abnormality. Right, there will also be a bleeding abnormality, and this particular bleeding abnormality is mainly because of the platelet storage pool defect. right? It is due to the platelet storage pool defect. That is what is your Hermansky-Pudlak syndrome. Whereas Nelson syndrome, when will you develop this Nelson's is whenever the patient is done with bilateral adrenalectomy, right? When the patient undergoes bilateral adrenalectomy, in response to that there will be decrease in corticosteroids and there will be increase in ACTH, and once there is increase in ACTH there will be parallel increase in MSH. That will cause the hyperpigmented skin. Whereas you take Addison's, so Addison's, right, there will be decrease in corticosteroids. In response to decrease in corticosteroids there will be increase in the ACTH, right? As there is increase in ACTH, there will also be increase in the melanocyte stimulating hormone, and that will be responsible for hyperpigmentation. So Nelson's, Addison's and as well as Busulfan, you will have hyperpigmented skin, but not in case of the Hermansky-Pudlak syndrome, right? Next question.